Good morning, everyone, and welcome to today's PD Active virtual speaker forum. My name is Todd Morrish, and together with Monique Buffler, we will be your hosts and moderators this morning. Before we introduce today's speaker, a little bit of administrivia as I read through my notes here. First, as you may have heard, in November, PD Active transitioned from a pay-per-class model, or in the events case, a pay-per-event donations model, to a no-charge model. PD Active wants to be absolutely sure that everyone who wants to attend a class or a support group or a speaker event can, with no pressure. PD Active will continue to run our annual appeal, which we are in the later throes of right now. And we remain grateful for your support there. If you would like to donate to our annual appeal, you may do so via the green donate button on our site. And Monique, if you wouldn't mind pasting that from the notes into the chat window, that would be terrific. Next, we always like to take a moment here to cross-promote PD Active's wonderful programs that I just mentioned. PD Active's highly regarded support groups now include one for Spanish speakers specifically. We also offer Tai Chi and yoga and Pilates and meditation, and there's voice and singing and boxing and dance and much more. If you have tried one of these, we ask that you please tag a friend or family members to join you on your next session. Please check out the calendar link on the pdactive.org website, and we'll paste that into this Zoom chat tool also right now. Quickly, some upcoming events that you can look for from the events committee for the PD Active board is next month on February 11th, we will have a roundtable entitled, "Is it time to park the car?" So we'll be dealing with the sensitive topics around sensitive questions and discussions around that topic with a specialist from the field. March 11th is our next virtual speaker forum on hallucinations and dementia with PD. And then also stay tuned to the newsletter for information on our mini info fair coming up in the spring. So one important note, as you may have heard a moment ago, this webinar is being recorded, and we will post that recording to our PD Active YouTube channel in the next few days. We'll also put that in the chat window right now. Thanks, Monique. Throughout our presentation this morning, we will present you with a small handful of poll questions, which will pop up on your Zoom screens. Please answer these as quickly as you can so Dr. Ashbrook may respond to them in the flow of her discussion. If you prefer to not answer the questions, merely close the windows when they pop up. You can also grab the top of the dialog box that pops up and slide it out of your way so you can see the screen and the results of the poll. In fact, we'll start with one right now. A quick question that Dr. Ashbrook will help Dr. Ashbrook better understand the audience. So Monique, do you see that poll? There you go, folks. Take a look at that and give us an answer there as I continue to read through my notes. If for any reason any of the three of us gets disconnected from this webinar, which I highly doubt, please be patient and do not disconnect or leave the meeting for a few minutes as we try to get reconnected. It is possible that Monique may take over for me as host if I am disconnected. Please submit any questions you have for our speaker via the Zoom Q&A feature. They're in the tool tray at the bottom of your Zoom screen. You may do so at any time during the forum, and Monique and I will use the Zoom's chat tool to deliver information to you, as she's been doing already. Okay, here we go. Let's publish that. Clearly, most of us have a PD on this call, with a handful of care partners and caregivers and family members. So there you go, Dr. Ashbrook. That's a good lay of the land for you on the audience demographics there. All right, here we go. By show of hands out there, who among us is tired right now? I am, and I can't see your hands, so I was kind of kidding there, but I'm guessing a lot of hands popped up there. So let's talk about sleep and PD. PD Active is thrilled to have joining us today Dr. Liza Ashbrook. Dr. Ashbrook is a neurologist at UCSF Health who treats general neurology patients, but with a focus on those suffering from sleep disorders. Her research focuses on understanding rare circadian rhythms and sleep homeostasis traits. Dr. Ashbrook earned her medical degree and completed her residency at UCSF. She completed a fellowship in sleep medicine at Stanford University. She is a member of the American Academy of Neurology and also American Academy of Sleep Medicine. Wow, that's a lot. Dr. Ashbrook, welcome to PD Active's virtual speaker forum series. Thank you very much for loaning us some of your precious weekend family time. we're glad to have you. So if you would like to take a minute to add to anything in that intro, feel free to. Otherwise, grab the share screen option and take it away with your presentation.
Great. Thank you, Todd and Monique, very much for having me. And I look forward to speaking with you all. So let me go ahead and share my screen. All right. I trust you can all see that now. Great. All right. So again, thanks for having me. I'll talk today about sleep medicine and sleep in Parkinson's disease specifically. So let's get started. So we'll go through why do we sleep? What are key ideas about sleep and features of sleep? Why should we worry or think about our sleep quality or duration? And then we'll go through some patient cases with some different sleep disorders in patients with Parkinson's disease, including sleep apnea, restless leg syndrome, REM sleep behavior disorder, insomnia, and excessive sleepiness, also called hypersomnia. So all animals that have been investigated have a sleep state. While it may not look exactly like the sleep state in humans, it seems that sleep is very, very highly preserved evolutionarily, which suggests that it's incredibly important given all these different animals are sleeping, from C. elegans to bats, flamingos. However, one of the big mysteries remaining in biology today is, why do we sleep? Intuitively, we know why we sleep: to cure sleepiness, to feel more refreshed in the morning. But actually, scientists and researchers do not perfectly understand what the role of sleep is. Here are some of the things we do know. We know sleep is very important for memory consolidation and for pruning memories. So you don't remember what you had for dinner 3 weeks ago? Neither do I. Those are memories we don't need to hold on to, and sleep helps us forget unimportant things. We know sleep is really important for mood and emotional homeostasis. We all know the term sleep on it, right? As you're processing something, sleep can be really beneficial. Waste removal is a role that has really been emerging in the last decade. About 10 years ago, a system called the glymphatics was described, which helps cleanse the brain of waste products. So during the daytime, our brain is very active and creates some waste, which is largely cleared out during sleep. And we're learning more and more that proteins like alpha-synuclein that are deposited in the brain in people with Parkinson's disease are largely cleared out during sleep. And so it may be that sleep is an untapped resource to combat neurodegenerative diseases like Parkinson's and Alzheimer's. So while that won't be a focus of today, that's an area of burgeoning research. So how much sleep do we need? This is a slide from the National Sleep Foundation, or a graphic from the National Sleep Foundation. And these are some general recommendations. And I'm showing this here because people often, when thinking about sleep, wonder, well, how much sleep do I need? And so it shares here that adults need 7 to 9 hours in 26 to 64 age, older adults 7 to 8. However, there's a lot of person-to-person variability. We know some people need more and some people seem to need less. And how much you as an individual need may not be the same as what your neighbor needs. And so while this is a useful guideline, I think anchoring on getting exactly this amount may not be the right thing for you. So I think taking this information with a grain of salt is useful. But it does we can use it as a jumping off place to think about, where did the information about how much sleep we need even come from? It's mainly from studies, the epidemiologic studies, looking at large groups of people and asking them how much sleep they get, and then seeing what kind of health problems develop, alongside studies of sleep deprivation, where people are forced to sleep in experimental conditions, shorter durations, and problems are looked at. So I'll talk to you a little more about that kind of research. So I see most people here are getting 6 to 8 hours of sleep, with some getting less and some getting more. And that's actually, what we see in the population as you'll see on this slide. So there is a U-shaped curve that looks at sleep duration and a large number of health outcomes. This slide shows a graph related to mortality. So let me help explain this here. On the left, these two graphs are for women, and on the right, they're for men, but they're very similar. At the top, it looks at the hazard ratio or risk of dying in the observed time, and at the bottom, the hours of sleep. So in this study, a very large number of people were asked, how much have you been sleeping? And then the people were followed over about 6 years, and they looked at what kind of health problems emerged, namely who survived. And they see that people who are sleeping less and more than 7 to 8 hours of sleep actually had a higher mortality rate, which is interesting, suggesting that those are not good signs. But this isn't causation. This is a correlation. It's a study that observes a pattern. And so it could well be that people who are sleeping less and more already have some other kind of medical problem that's leading them to sleep less or more that might also increase risk of mortality and just be a marker for a problem going on. But it certainly has raised concern that too little sleep can be dangerous. Too much sleep is pretty widely accepted as probably a marker of another kind of problem and had been investigated a bit less. This U-shaped curve, I should add, has been shown for cardiovascular disease, diabetes, a huge range of other medical problems, and generally shows that 7 to 8 hours is the ideal amount. So that's one of the things that has driven this proclamation that is the amount of sleep that people need.
And Dr. Ashbrook, at the bottom of each of those graphs, there's a number of men and women. Is that the total number?
That's how many people were in this specific study from Kripke and colleagues, published in 2002. Exactly. So that's how many people were surveyed in this study. And there's a number of other studies that have similar data, but this one is a very large one.
Thank you.
And then there's a number of studies that look at sleep deprivation. We're not going to dive into all of those details, but I will share with you that sleep deprivation has been associated with a huge range of medical issues, probably not surprising to you. It's been associated with impaired glucose tolerance, which can lead to diabetes, with emotional dysregulation, problems with attention and memory, divergent thinking, and problems with originality, impaired flexible decision-making, increased risk-taking, and impaired immune function. And I should add that it's not solely insomnia. In this past study, just going back one slide here, they also asked people if they had insomnia, and they didn't see an association of insomnia specifically with increased mortality. It was about duration of sleep. So, many of you know intuitively, if you're experiencing a bad night of sleep, or you had to get up earlier than you want, or you ended up going to bed significantly later, that you may feel that a lot of these things, like your emotional regulation, is impaired. But of course, it's harder to notice their glucose tolerance may be different. And then the immune function is an interesting one. I'm going to share a little bit more about that. This is actually research that was done by a colleague of mine, Eric Prather at UCSF, pre-pandemic, but I think it's really pertinent now as we think about risk of getting COVID and our immune response to vaccines. So in a couple studies, he looked at this. He asked people and actually measured by actigraphy, which is like a medical grade Fitbit, how much people were sleeping for a week. And then he took a cold virus, rhinovirus, and squirted it into people's noses. And he followed them for days to see who got sick. And as you can see in this graph, there was a clear matchup between how little sleep people were getting and how likely they were to get a cold when exposed to the cold virus. So people who were sleeping fewer than 5 hours were significantly more likely than people sleeping over 7 hours to get a cold virus after this exposure. And then there was another study done by Dr. Prather looking at sleep duration, also measured by actigraphy, which is, again, looks at movement and light via a wristband, and response to a vaccine. And they saw that in the night before, you get a vaccine, specifically the Hep B vaccine in this study, but one can extrapolate it pretty confidently to other vaccines like COVID, you're more likely to actually mount an antibody response, which is the desired response, actually have your body create the desired antibodies if you've gotten more sleep compared to which is over 7 hours in this analysis, compared to fewer than 6 hours. So I don't think that's something that people are often thinking about, but even the immune system is impacted by sleep. And exactly by what mechanism is yet to be understood. Another area that this is very important is sleepiness, and that relates to driving safety. So of course, we all know that one reason we sleep is so that we're not as sleepy. And sleepiness is incredibly important from a safety perspective, as well as, of course, a day-to-day function perspective. And drowsy driving is a cause of fatal motor vehicle crashes. In 2020, about 2.4 of motor vehicle crashes were attributed to drowsy driving. However, some people who study this area really estimate that far more than that are actually have drowsy driving as a contributor, and that it may go unrecognized if there's another factor at play as well that the accident is blamed on. And then maybe up to a third of fatal crashes involve a drowsy driver. And if a driver is drowsy, data suggests that an accident is actually more likely to be fatal. What puts you at risk of drowsy driving? I think these things are intuitive. If you're sleeping less, typically less than 6 hours. Snoring may suggest sleep apnea or some disrupted sleep. And then if you're unintentionally falling asleep at other times of day, you're more likely to unintentionally fall asleep when driving. So let's move on to how is sleep studied. So there's two main types of sleep tests. There's something called polysomnography, and that is also termed PSG, or attended sleep study, or in-lab sleep study. It's when someone comes into a sleep lab and actually spends the night there. So they might come in the evening at 8 p.m. and leave in the morning, 7 a.m. or so. And there's a bunch of different wires that are put on you to evaluate sleep and breathing and movement during sleep. And you can see here's me as a sleep medicine fellow, and I have all the wires on almost, still need the nasal sensor, getting ready to do my own sleep study. You can share how many of you have actually had a sleep study. So what wires are involved in a sleep study? Well, there's EEG on the head, and this EEG picks up brainwave activity. And so it can help determine, is someone asleep? Are they awake? What stage of sleep are they in? There's leads around the eyes. These are important for looking at eye movement, which can help detect the stage of sleep called REM, or rapid eye movement sleep. There's a nasal sensor that helps look at breathing, chin leads that look at muscle tone, which is important also for detecting REM sleep. There also leads in the arms at times and on the legs that look at muscle tone. There's a pulse oximeter that looks at your pulse and your oxygen level in your finger, an EKG lead, a chest and abdominal effort belt. So a lot of wires that can help analyze sleep. All right, so some of you, it looks like most people have not had a sleep study, but a good number of you have in fact had a sleep study. And then a home sleep test is a lot simpler. Most commonly, it's a nasal sensor, a probe on the finger, and a chest effort belt. And its really main purpose is to evaluate for sleep apnea. So this is a little more information about sleep. On the right, these little tracings are EEG. So again, an EEG is like a sticker on the head, and it picks up the electrical activity in the brain. It doesn't deliver anything, but it senses the electrical activity in the brain. And by doing so, we can actually look at sleep, tell if someone's awake or asleep, and then define different stages of sleep. And you can see that different stages of sleep look different. So at the top, we have awake, and you can see there's pretty low amplitudes, mix of frequencies. As someone gets drowsy, the amplitude heightens, and then stage 1 sleep, some of the kind of background fast activity falls away. Stage 1 sleep is a transitory stage. We only spend about 5% of our night in stage 1 sleep. That goes up a little bit as we age. In stage 1 sleep, if you're awoken, you may not have even felt like you were sleeping. It's very easy to awaken someone in stage 1 sleep. A door closes, someone whispers your name, and you're likely to wake up and kind of feel like you were nearly asleep. Stage 2 is characterized with a background that looks like stage 1, but then a few other characteristics. Sleep spindles are these periods of very fast activity. These are important for learning and memory. And then K complexes, you can see on the right of the stage 2 area here, is a large up wave and down wave. And this really stands out from the background. It's important for learning and memory as well. It's also important for gating the brain. So an environmental noise, like a bang in your environment, can actually trigger a K complex in someone who is sleeping. And so it's thought that it may be something that actually helps keep you asleep in a noisy environment. We spend nearly half of our night in stage 2 sleep. Delta sleep is where we go after stage 2. And delta sleep is also called N3 or slow wave sleep. This is where our brain seems to really be relaxing in a sense. If you awaken from stage 3 sleep, you feel very groggy and drowsy, and it can be very challenging to wake up. If you set your alarm early in the morning for an airplane flight or another obligation, and it's so hard to open your eyes and get out of bed, you may have been in stage 3 sleep, or also called delta sleep. In this stage of sleep, this is where we think that a lot of that cleansing of the brain occurs, and it probably also delivers a lot of the refreshing properties that we associate with sleep. And then finally, there's REM sleep. This stands for rapid eye movement sleep. REM sleep has some really distinct characteristics. It was first described in the 1950s, and interestingly, when it was first described, people didn't believe it. So this was following the first overnight recording of sleep by EEG, where they first saw that the brain seems to cycle into this period in the deep of the night where somebody looks very asleep, and yet their brain actually looks quite awake. You can see this EEG tracing looks a lot more like stage 1 sleep or even wake than it does like other deep stages of sleep, delta sleep. So people thought, how is it possible that the person looks so asleep and yet the brain looks so awake? And we now know by studies that look at things like PET, which is kind of metabolic activity while we sleep, that the brain is in fact quite very active during REM sleep, similar to wake, as compared to delta sleep, where the activity or the glucose metabolism in the brain actually drops quite dramatically. In REM sleep, some of the regulation of breathing and heart rate are also change, and you can see fast and slow heart rates. And this is where we have our vivid dreams. So if you wake up during REM sleep, you may feel like you were in a vivid dream. Typically, our bodies are paralyzed during REM sleep, probably so we can't act out our dreams. But as many of you know, sometimes people aren't paralyzed, and this tends to be something that's associated with Parkinson's disease. So this is a kind of cartoon of how we cycle through these stages. It's never quite so clean as this, and yet we do generally see for most people undergoing a sleep study that this is the pattern. You go into stage 1 or N1, stage 2, also called N2, and then N3, and then jump to REM. You might wake up in that period of time, and then you continue to cycle through those stages. It takes about 90 minutes to cycle through. In the beginning of the night, the stages of REM are shorter. You may not even have a stage of REM in the first cycle. And in the beginning of the night, the stages of N3 are longer. And by the end, you may not even have a bout of N3 sleep. And we all generally follow this pattern, even if there are more sleep state transitions in a more classic real life example. This is called a hypnogram. So what makes you sleepy at certain times of day? I think this is a really useful model to have in mind if you have a sleep problem like insomnia and are thinking about how to solve it. So this model was first described in the early 1980s, and it's really hung on because it really does a good job of describing the processes that lead to us being sleepy at night and awake during the day. These two processes are called sleep homeostatic pressure, or process S, also called sleep drive more colloquially, and circadian forces, or process C. So process S, or sleep drive, rises as a function of how long we've been awake. So if you wake up after a decent night of sleep, your sleep drive is low. and then it slowly mounts throughout the day. If you stay awake all night long, your sleep drive will continue to mount. This is balanced with our circadian drive or circadian forces. And this rises and falls as a function of how long, of the time of day, rather, not how long you've been awake. So the circadian forces actually help you stay awake in the latter portion of the day when your process S or sleep drive has gotten pretty high. And it helps you stay asleep in the latter portion of the night when you've already dissipated much of your sleep drive. And so it's circadian forces that help you consolidate your sleep into one bout at night, or largely one bout, and sustained wake during the daytime. Sometimes as people get older or with a disease like Parkinson's, some of the circadian mechanisms may not function as well. And sometimes people's sleep ends up breaking up quite a bit, and they're napping more during the day and having more trouble staying awake at night. Well, there can be numerous reasons for that. It can be related to kind of a breakdown of this process C, which helps us consolidate into wake and sleep.
And Dr. Ashbrook, I have a quick question on that slide, if you would.
Sure.
The sleep drive or the sleep process red line, if we didn't go to sleep in this graph, it says 2300 o'clock, right? 11 o'clock. Then how can you, why would that red line not automatically peak down? Because you're running out of energy, in theory, you're running out of energy and rest, right?
So the drive doesn't represent your energy per se, it represents your sleep drive, the line does. So it mounts as a function. It's not perfectly straight, it may kind of curve a bit, but it just mounts as a function of how long you've been awake.
Okay.
And it's representing your drive to sleep. But because it's balanced with the circadian forces, it's not going to be equal at every minute. So often in the evening, people might feel actually a bit more awake because their circadian forces are helping them stay up, and then they hit bedtime. And in the middle of the night, we tend to feel the sleepiest. And then by morning time, if you were to stay up all night, you actually might feel a little more awake, even though you've been up for 24 hours. And that's probably because your circadian forces are helping you wake up and it's morning time. And so there's other stimulating forces, even if your sleep drive is actually very high. And it's something we think quite a lot about when we think about treatment of insomnia. And so we'll talk more about that when we talk about insomnia treatment. But
Good.
Thinking about having mounted an adequate sleep drive to actually go to sleep is important if you're not sleeping well.
Thank you.
Sure. So just a bit more about the circadian system. So in our brain, in the middle of our brain, is an area called the suprachiasmatic nucleus, pictured here. And this is the central timekeepers for our body. So there are cells here that keep a 24-hour rhythm. Even when they're put in a little dish, they keep about a 24-hour rhythm. Actually, many cells in our body keep their own rhythm, but this is really the central timekeeper, or the conductor for the time for our body. And why might we need to know where we are in the 24-hour cycle? Well, this, similar to sleep, has been evolutionarily preserved and observed in many different animals and plants. And likely it's important because it allows us to anticipate when we will be seeking food, when we should be storing food. You know, our liver wants to know if it's going to be taking in sugars and food, or if it should be releasing what it's stored because we'll be fasting overnight. When we're expected to be active, when we should be sheltering. Understanding where we are in that 24-hour day is very important for our bodies to function properly. And actually, many of the proteins in our body are actually activated or transcribed based on the time of day. The main input to this internal clock in our brain is light, specifically sunlight. So exposure to sunlight is really important for telling our brain when we actually are supposed to be active during the day and asleep at night. And our bodies are not adapted to the artificial lighting environment that we all live in now. And so all the artificial light at night, and sometimes the lack of good sunlight during the day, can also derail this system. And so if you're concerned that maybe your circadian system isn't functioning as well, one big thing we focus on is getting really good sunlight during the day and minimizing light in the evening. And the suprachiasmatic nucleus, or this area in the middle of the brain, it sends that information all over the body. and has an influence on the different functions of hormones and functions of numerous organs. So in Parkinson's disease, why do we think about sleep specifically? As you can tell me better than this slide and research papers, sleep problems are very, very common among individuals who have Parkinson's disease. So research has shown 55 to 80% of people with Parkinson's complain of sleep trouble. I think estimates can vary, but it's the majority of individuals. And while treatment often focuses on motor symptoms and sometimes on other non-motor symptoms, sleep is not always a focus, despite it being an incredibly common problem. And people have commonly cited it when asked as one of the most bothersome non-motor symptoms in Parkinson's disease, though it doesn't always get the airtime that maybe it deserves. And about 40% of people are actually on medications for sleep who have Parkinson's disease, which is greater than the general population. So let's walk through some cases of patients who have Parkinson's disease and sleep concerns. So the first case is Miss A. She's a 64-year-old woman. She was diagnosed with Parkinson's 3 years ago. So here we can see, so a lot of people have a range of different sleep issues. So typically just walking through what we see from your feedback, nearly half of people have difficulty falling asleep or staying asleep. Restless leg is also pretty common, snoring or sleep apnea, akathisia, dystonia, nocturnal urination. These are all common problems. So this is interesting, but what it fits with kind of what's been shown in studies looking at these problems among people with Parkinson's. So hopefully walking through some of this will be useful, since I do see these problems are quite common. So this woman, 64 years old, she has Parkinson's disease, diagnosed 3 years ago. She's coming in saying she has trouble. She came to the clinic saying she has trouble falling asleep and staying asleep. It's happening like a couple times per week, 1 or 2 times. And when asked a little more, she says for about 5 years, she gets this electric shock feeling in her legs, or sometimes it's a creepy, crawly feeling. And she has this sensation and it kind of builds until it's impossible to hold her legs still. And when it's worst, sometimes she actually has to get up and walk around. And she says there have been times where she had to get up and walk around nearly all night and she didn't get to sleep until the early morning. So for those of you who experience this, you might recognize this problem. This is restless leg syndrome, or RLS. So what is RLS? So I've listed the criteria here. If you're wondering, well, I get something kind of like this, but I haven't talked to my doctor about it. Here's the criteria. So it's an urge to move the legs, usually, but not always, accompanied by an unpleasant or uncomfortable sensation in the legs. It's almost always the legs. The other parts of the body is possible, but the legs is kind of typical. And symptoms are partially or totally relieved by movement, like walking or stretching, at least as long as the activity occurs. And then this urge or need to move is accompanied by unpleasant sensation. It actually worsens during rest or inactivity. So if you're just sitting still, it can occur in the daytime, but it's most common in the evening or night. And we do see this circadian pattern of restless leg syndrome where it tends to be much more common at night, not solely because of the period of rest, but certainly linked to that in part. And then, of course, it's not better explained by something else. I didn't list that as a criteria, but that's part of many listed criteria in manuals and guidelines is, of course, if this is explained by something else, then it may not be restless leg. But sometimes people do have things like neuropathy or leg cramping and then have restless leg as well. All right, so that's the criteria. How do we treat restless leg syndrome? So restless leg is more common in people who have Parkinson's disease. It's also been associated with low iron. And so oftentimes your doctor will check your iron levels. And if your iron is low, then you may be instructed to take supplemental iron or increase iron in your diet. There are certain medications that can actually worsen restless leg syndrome. So we always want to look through someone's medications and see, before we add a medication, might we actually be able to stop something that will help with the symptoms. So kinds of medications that are associated with restless leg include antidepressants, antipsychotic medications, certain kinds of anti-nausea medications, and antihistamines. There are certainly times that someone is on an antidepressant and it can't be stopped. They need to take it for their mental health. And in that case, we work around it. But some, like Remeron or mirtazapine, commonly used also for sleep, is particularly a particular culprit in triggering RLS. So it may be that someone can change to a different antidepressant that may be less of a trigger. Moderate regular exercise can help restless leg syndrome. So inactivity and extreme activity have been shown to be triggers. And if you have restless leg, you may have observed that in your own life. Caffeine and alcohol are triggers, not universally, but many people notice that. And then sleep deprivation is also a trigger. Now, if you tell somebody who's experiencing restless leg every night, just get more sleep, that can feel very frustrating because, of course, they're trying and the restless leg is getting in the way. But if it's only intermittent, maintaining a regular sleep routine can actually be very important for keeping symptoms at bay. Hot showers and baths can help. A lot of people find leg massage or stretching is helpful, or pneumatic compression devices. And then a weighted blanket, that hasn't been actually researched, but many people find that is useful, at least for mild restless leg syndrome.
Dr. Ashbrook, is there any understanding out there as to why restless leg happens almost exclusively at night and not during the day?
There is some research. I would say that mechanisms are not perfectly understood. So there's probably some kind of buildup, like there's a process of, dopamine is involved because we know that dopamine medications are used as treatment. And of course, this is more common in people with Parkinson's. So there may be some process of like um, uh, areas of the brain that are building up and then breaking down certain proteins, but I don't know the answer. And I think it's not perfectly understood. But it is very interesting. And it's something that I've had patients who experience restless leg and then they travel to Europe and they experience it during the daytime as at worst while they're still jet lagged. So it really does kind of fit with the circadian rhythm rather than a time of day.
Interesting.
Yeah. And so medications that are used for restless leg syndrome, the two main categories of medications are what are sometimes called gabapentinoids. These are medications similar to gabapentin. Gabapentin was originally developed as a seizure medication. It's essentially not ever used as a seizure medication now and is used for a range of things, including nerve pain and restless leg. A couple of similar medications, pregabalin and gabapentin and acarbol, are also used for restless leg. And then dopamine agonists, pramipexole, ropinirole, rotigotine. For many years, the dopamine agonists were actually the first line treatment for restless leg syndrome. And that's fallen out of favor a bit now because of two kind of odd side effects that these medications can have, which many in the audience may be aware of. One are impulse control disorders. So this is a symptom or a phenomenon that doesn't feel like it should be a side effect of a medication. But this is when people make decisions that in the short term might feel good, but in the long term are dangerous, like gambling or excessive online shopping, and can actually come about as a consequence of being on one of these medications, the dopamine agonist medications. And then the other sort of odd side effect is a phenomenon called augmentation, when the medication seems to actually perpetuate the symptoms, like someone's on it for a long time, might be doing well, and then things worsen and worsen and worsen despite escalating doses. And people think it may be the medication that's kind of triggering that escalation of symptoms. And so because of these side effects, the kind of people have shifted somewhat to using gabapentinoids more commonly as the first line treatment for restless leg. But it depends on the individual, the circumstance, and what's going on in terms of other medical issues and other symptoms. But rarely some other things might be used. If someone's iron is very low, maybe an iron infusion. Opioid pain medications are rarely used. Benzodiazepines are rarely used, but it can be effective. All right, let's shift to case 2, Ms. X. So this is a 54-year-old woman with Parkinson's disease and depression who came in to clinic saying that since she was pregnant 14 years ago, she's had trouble falling asleep. And as she's going to sleep, her right arm and leg can feel really stiff. She's been talking to her doctors about getting deep brain stimulation, DBS, and that's been actually worsening things recently and part of what prompted her to come to clinic now. But she's been having a lot of anxiety about that and a lot of thoughts every time she goes to sleep about the risks and benefits. When asked when she goes to bed, it varies, sometime between 11 and 3. That's taking her hours, 1 to 3 hours typically, to fall asleep. Overnight, she awakens 1 or 2 times, and if she does wake up, she has trouble going back to bed. And then she gets out of bed at variable times, sometime between 7 and 9. And if she's not sleeping, she often picks up her phone and watches something on it or reads the news. She doesn't report snoring or restless leg symptoms. So what does she have? This is insomnia. So insomnia is defined by trouble falling asleep or trouble returning to sleep, along with a complaint about dysfunction during the day or dissatisfaction around sleep. So a lot of people with Parkinson's disease have insomnia, maybe around 60%. The estimates can vary depending on how you ask and who you ask. It's more likely to occur in women, those who've had Parkinson's for a longer time, those who also have depression or anxiety, and in people who have memory complaints. And then in the general population, sleep initiation insomnia, meaning falling asleep at the beginning of the night, is more common. But actually, among those with Parkinson's, sleep maintenance insomnia is more common, meaning trouble going back to sleep after awakening in the middle of the night. Though many people have both trouble falling asleep and trouble returning to sleep. So, why might people experience insomnia more commonly in Parkinson's disease? Many of you can tell me these answers. So, symptoms of Parkinson's disease can disturb sleep: dystonia, akathisia, restless legs, cramping, tremor, difficulty turning in bed, circadian clock disruption, needing to urinate at night or urinary incontinence. All of these things that may be bothersome related to Parkinson's disease can also be big disruptors of sleep. So, how do we treat that? So, if someone comes to our sleep clinic and has Parkinson's disease and complains of insomnia, one big thing is making sure that motor symptoms are optimized at night. And this is something we do in conjunction with your Parkinson's doctor. So, oftentimes, long acting dopaminergic medications like controlled release carbidopa levodopa are used, or sometimes rotigotine transdermal patch. And this can actually help quality of sleep, help people fall asleep more quickly, and actually stay asleep. And then treatment like DBS has actually been shown to also improve sleep, probably related to improving these motor symptoms overnight, though there other mechanisms have been speculated, but they haven't been clearly shown. And then urination overnight is a big issue for a number of people, but very much so in Parkinson's. And there are a number of medications for this, and sometimes even Botox is used. And I've certainly had patients who, once they did get adequate treatment of their nocturnal urination, their sleep did improve quite a bit. And then we always want to make sure, if we think something's insomnia, that there's not something else disturbing the sleep, like restless legs or sleep apnea, and that we shouldn't be kind of targeting that when we really think about optimal treatment. So, assuming we don't find another explanation and adequate treatment of Parkinson's symptoms overnight hasn't adequately resolved insomnia, what do we do? So you're probably familiar with the term sleep hygiene. So sleep hygiene can mean different things to different people, but essentially means avoid practices that hurt sleep and do practices that help sleep. So you want to avoid caffeine in the latter part of the day. Caffeine can stay in the system 10, 12 hours. So I generally recommend that people not have caffeine after noon or so, depending on when you're trying to go to sleep. And some people say, well, sometimes I have caffeine and then I fall right asleep. Yeah, that may happen sometimes when the sleep drive is high enough to kind of get you over the hump of having caffeine in your system. But if you're routinely experiencing trouble falling asleep, no need to put up other barriers like having caffeine in your system. And while that is typically not the sole reason someone's having trouble sleeping, we want to get everything in line to help someone sleep better. Alcohol. Alcohol may make people feel like they're falling asleep more quickly, but it's very much a sleep disruptor. And so if someone's really having significant sleep trouble, a big part of getting a handle on that can be reducing alcohol use. And then nicotine is also stimulating. And then creating a good sleep environment, having a cool, dark, quiet, safe sleep environment. That by itself is not enough to cure insomnia, but it is really important for maintaining good sleep. And then practices that help sleep: exercise routinely, having a bedtime routine, avoiding bright lights. Those are all really important for maintaining good sleep. That said, sleep hygiene all by itself is really not considered adequate to treat insomnia in most cases. So these things are incredibly important for a good baseline and to maintain, to make sure that sleep doesn't get further derailed, but by themselves are typically not enough. So what do we do beyond these pieces? Well, it's considered the first line treatment for insomnia among sleep specialists is something called cognitive behavioral therapy for insomnia, or CBTI. So this is therapy that most formally is working with a sleep psychologist, usually for a few months, about 5 to 7 sessions total. And the treatment involves kind of what it sounds like, cognitive strategies and behavioral strategies to get a handle on sleep. So behavioral strategies focus on consistency, but not consistency like get yourself to bed at 9 no matter what. You have to get yourself to bed when you're sleepy. One pattern we see commonly is when people aren't sleeping well, they give themselves more and more opportunity to sleep. So say someone gets up typically at 8 and they haven't been sleeping well, so they want to get themselves to bed at 9. Well, that individual is giving themselves 11 hours in bed. And most bodies are not going to produce 11 hours of sleep. So if you give yourself 11 hours in bed, you are building in a lot of wake time. And wake time in bed is inherently frustrating. And so that is self-perpetuating. You lay there frustrated, and that only builds more frustration and makes it harder to sleep. Further, it fractures the sleep. And we know people get lower quality sleep when their sleep is spread out over a longer period of time. And research has actually shown that you get higher quality, more of that really deep stage 3 sleep if you consolidate your sleep over a shorter period. So we recommend don't go to bed until you think you're actually going to fall asleep. And a very stable wake up time and minimizing naps is also important. So some people feel like they have to nap, or if you're going to drive and you're at risk of falling asleep, then yes, a nap is important for safety. But if you're experiencing trouble sleeping at night, removing naps or keeping them very short is helpful. If you think back to the graph about sleep drive and circadian forces, you can imagine that if your sleep drive is mounting as a function of time awake, and then you bump it down because you nap, by the time you get to bedtime, your sleep drive won't be as high. And you really need it to be at its highest to get you to fall asleep and stay asleep throughout the night or return to sleep as necessary. And it's not one-to-one. You don't nap for 15 minutes and then bump just 15 minutes off your sleep at night. Our bodies are more complicated than that. And you can nap for just 15 minutes and bump hours off of your sleep, especially if those 15 minutes are quite close to bedtime. And then CBTI, or cognitive behavioral therapy for insomnia, also involves cognitive strategies and relaxation methods. We conceptualize insomnia as a problem, not with sleep actually, but with wake. Our bodies are so awake that it doesn't let sleep in. And so part of CBTI is breaking down some of the anxiety that's associated with insomnia and the hyperarousal so that sleep can come in. So while CBTI is our first line treatment, there are circumstances where it doesn't work. It's been compared in research to sleep medications, and it's as good, if not better, than sleep medications. But again, there are some people who medications are necessary. There's not a lot of research on sleep medications specifically in individuals with Parkinson's disease. There's a few studies. Something looked at melatonin, another study looked at doxepin, also called Silenor, another study at zopiclone, also called Lunesta. And these studies showed that subjectively, like by someone's report of their experience, sleep did seem to be helped, but objectively, measuring with a sleep study, it didn't seem to make a significant difference. And people are using these medications along with other ones that are used in the general population with insomnia: Ambien, Sonata, Trazodone, mirtazapine, orexin antagonists. So there's a number of medications that are used for sleep. But we do think that they have potential downsides. So when able, we do try to avoid them. So this is a study that highlights potential downside. Now, we don't know for sure that there are long-term risks associated with some of these sleep aids, but this is a study of a very large study, looked at nearly 60,000 people in Taiwan. And they looked at people who were put on zolpidem, also called Ambien, and those who had insomnia but were not put on zolpidem. And they actually saw that people who were put on zolpidem had a higher risk of developing Parkinson's. Now, people don't know based on this study does the medication cause Parkinson's, or is it just kind of a marker for people who had more severe insomnia? Because we know insomnia is associated with Parkinson's. And so the people who got put on this medication just were ones who really more needed a medication. And that helped pick out people who were going on to develop Parkinson's disease. So we don't know that it's causative, but it has raised, studies like this have raised concern that there may be some long-term risks associated with medications like Ambien. It also can be sedating in the moment. It can increase risk of falls overnight. And so it's given some caution, but there are certainly circumstances where people feel like the benefit outweighs the risk.
And the subjects in that study, Dr. Ashbrook, did not have PD prior to the study.
Right, exactly. These were not people who had PD prior to the study. So they followed them and saw them develop Parkinson's, exactly.
So 30 to 40% is pretty high, I'm taking it.
It's pretty high. That was the percent increased risk.
Yeah.
And I would say that the general medical community has not concluded from this that Ambien causes Parkinson's by any means. We do know that oftentimes things like insomnia can be a precursor to a disease like Parkinson's. Like people get sleep disruption before they get the motor symptoms clarifying what's going on. But this, along with other studies, have definitely raised concern that, these medications may not be kind of as benign as people thought that they were initially when they first came out.
Let's see. And is it safe to extrapolate from that if someone had PD and is taking Zolpidem or the family of Zolpidem, their symptoms might get worse, their PD symptoms, or no?
No, I don't think so. I don't think there's any specific evidence of that. And I think it's kind of a case by case basis.
Mhm.
I mean, I have had patients who feel like well, this was not a patient with Parkinson's, just a patient with some memory concerns, who felt like her memory concerns got dramatically better when she was on a medication such as this because she was sleeping better, right? So it's not, and nothing else was working for her. So I think it depends on kind of this specific case, but we do, by and large, try to avoid this medication in people with Parkinson's or with any memory issues or neurodegenerative disease, because not only is there this question of long-term safety, but there's also a day-to-day side effect that people can experience. And if your brain isn't functioning as well as it used to, you may be at even higher risk of cognitive type side effects.
Okay, thank you.
Sure. All right, so case 3, 74-year-old man who has Parkinson's disease, and he's coming complaining of increased daytime sleepiness. So he's been taking an afternoon nap, and then he was driving recently and he fell asleep at a stoplight. He doesn't snore, but he does feel like his sleep is really fragmented. He's waking up really frequently at night. He says maybe 5-6 times. He goes back to sleep, but he doesn't know why he's waking up so much. Sometimes he doesn't, in fact, go back to sleep as well. So sleepiness is really common in Parkinson's disease. Estimates vary, similar to the other issues, maybe 5 up to 50% of people with Parkinson's, and that's higher than the population of people without. It's been shown to be more common in men, people who've had Parkinson's for a longer duration, people who have more severe Parkinson's symptoms. If you have chronic pain or other types of pain or depression, you're more likely to have sleepiness. And there's a number of causes, something disrupting the sleep at night, like restless leg or sleep apnea, underlying disease. So it's probably true that Parkinson's disease, along with damaging motor centers causing the motor symptoms of Parkinson's, also damage wake promoting centers, the underlying disease does. And so that's part of the explanation. Medications, so Sinemet and other Parkinson's medications can make people sleepy. And then circadian disruption. So wake promoting centers may be damaged. Circadian centers may also be damaged, so that it's harder to consolidate sleep at night and wake during the day, and sleep gets kind of spread out over the 24-hour day more, which manifests as both insomnia and excessive daytime sleepiness. And this is a study from 2014 that looked at melatonin levels in patients with Parkinson's disease. So melatonin is a hormone our body releases overnight. And it is, we talked earlier about the circadian system and this area in the middle of the brain called the suprachiasmatic nucleus. It, through a series of neurons, actually sends information to the pineal gland, telling the body to release melatonin at night. And so melatonin is thought to be direct output, or pretty direct output, of our internal circadian system. So this study looked at people who had Parkinson's disease and control subjects who did not have Parkinson's disease, and saw that people with Parkinson's had significantly lower melatonin levels. So you can see this top graph on the right. The circles are control, squares are Parkinson's patients, and on average, the numbers are a lot lower in people with Parkinson's. And then they specifically looked at people with Parkinson's, that's the bottom graph, and they separated people with Parkinson's into those who had excessive sleepiness as EDS, so people who were excessively sleepy and people who were not. And they showed even among those who have Parkinson's, people who were excessively sleepy had even lower levels of melatonin released. Now, you might think from this, well, I should just take melatonin at night, but it's not so simple, and it doesn't seem to really solve the problem. This is probably a marker of the breakdown of the circadian system rather than kind of a sole solution. So there's other components of our circadian system that help you stay awake in the day and sleep at night beyond just melatonin. So how do we treat excessive sleepiness? So there needs to be more research on this area, but one thing that can be useful is a light box or sunlight. So we talked before about how sunlight is the main input into our internal clock, or to our SCN in the middle of our brain that functions as our central pacemaker. So while it may feel like indoor lighting can be just as bright as sun, the way our eyes perceive it is quite different, like orders of magnitude different. So if you really want to activate that system, sunlight, even on a cloudy day, or a light box, which you can buy on Amazon or online, that mimics sunlight. Light boxes, the strength of the light is often measured in lux, and a typical kind of dose that you might find is 10,000 lux. And of course, you'd want to buy it without UV light. That's usually how they're offered. So a study looked at 1 hour of a light box in the morning and afternoon compared to a dim red light for 2 weeks. And they saw that people who were using this bright light box had less excessive daytime sleepiness, and their sleep at night was actually less fragmented, and they fell asleep more easily. So that is one pretty low cost intervention that is quite safe to try for people who have excessive sleepiness. And then stimulants are sometimes used. So caffeine, modafinil is used at times. Modafinil is kind of a weak stimulant or wake promoting medication that's used for sleepiness. It's used in like narcolepsy, but also in this context of people with Parkinson's and sleepiness. And so some people do find that helps. Not only might they find it helps with staying awake during the day, but sometimes people find if they stay awake during the day better, they actually sleep at night better. So it can help with insomnia as well. There's been some research on attempts to improve sleep overnight as well with medications. I would say that these two medications listed here, while they've been studied and there may be rare clinicians who use them for improving sleep at night, they aren't necessarily the optimal first step. Clonazepam is used for dream enactment, so there's probably people in the audience who are on that. But it has some downsides, so improving sleep at night is typically not a reason it's used. And then sodium oxybate is a medication that makes people very sleepy for short periods, like several hours, and it's used for narcolepsy. It was studied for excessive sleepiness and showed some benefits. So some people think it may be reasonable to use, but it has some risk associated with it. It can certainly increase falls at night. And so I would say I've not heard of people actually using this practically, just in a research study.
Dr. Ashbrook, quick question while you're on that slide.
Yeah.
Related to the light box and the recommendation of a morning dose and an evening or early evening dose.
Mm-hmm.
Is there anything wrong with using light box between those windows, or is it?
Not at all. No, definitely not. I think that's just the regimen they picked. And I think in clinic, we often focus on using the light box in the morning, in like a few hours in the morning, but getting some afternoon light is probably also beneficial. Probably using it too late in the day, depending on the nature of the sleep problem, could be problematic. But no, I think this was just an effort to spread it out and exactly how much light helps in what circumstances, something's still being explored, but absolutely in the middle of the day would be totally fine as well.
Good. I'm glad, as mine is blazing away here on my desk.
Wonderful. So sleep attacks, I did see, I think 4% of the audience noted that they've had sleep attacks. So sleep attacks are when people experience a sudden irresistible bout of sleep. And it's estimated to occur like in 1 to 6% or so of people with Parkinson's. So it seems like this audience fits within that. Sometimes it's attributed to medication. So specifically the dopamine agonists are potential culprits. But it's not perfectly understood. It doesn't seem to be exclusively in that context. And it's usually in people who do have excessive daytime sleepiness, but 1 in 5 people in one study didn't in fact report excessive daytime sleepiness, but despite that experienced sleep attacks. So it's particularly concerning from a safety perspective. So if you do experience sleep attacks, from a safety perspective, you shouldn't be driving until it's effectively treated. And so we evaluated in a similar way to sleepiness, thinking about, is something disturbing your sleep? Are there medications that could be changed or removed or tinkered with?
Dr. Ashbrook, I have a quick question. So if you're laying down and you're on the couch and it's Sunday afternoon and you're reading a book and you fall asleep, is that considered a sleep attack? Or is it
I would
more
not
like,
consider that a sleep attack.
okay, so it's
That
more
doesn't
like,
seem like yeah, that seems more like you put yourself in a circumstance where you weren't adequately stimulated. And so I think a sleep attack is more when it's coming about at a very surprising time, like a
right.
time when you actually are pretty stimulated and required to be awake. I mean,
And how's that different
there
from
are people who,
narcolepsy?
so narcolepsy is a very specific disorder where there's an area of the brain that produces a certain kind of neuropeptide that's deficient. And it's an autoimmune disease. So it's totally different mechanistically. And people who have narcolepsy may experience sleep attacks, but they are uniformly very sleepy. So it's different in many respects in that way. But people who experience sleep attacks generally report that comes on very quickly. So I suppose if someone were reading and they came on very quickly, they might call it a sleep attack. People kind of conceptualize their problems in different ways, and so it is possible someone could call it a sleep attack. But I wouldn't be so concerned if it really only came on at a time when someone would be very safe to fall asleep. It would be obviously much more concerning if it came on at a time where they aren't safe to fall asleep, regardless of kind of how quickly it comes on. All right, so case 4 is Mr. Z, 69-year-old man. He has Parkinson's disease, who came into clinic with his wife. He said he was diagnosed with Parkinson's 3 years ago. His wife is concerned because he's swinging his arms in his sleep and he's kicking, and he's hit her on occasion. He doesn't often recall this, but sometimes he can recount like lunging out of bed. Once he awoke and he felt like he was running to save his wife from a fire, and he's broken a rib from lunging out of bed. And looking back, he says, yeah, 20 years ago, his wife reported he was mumbling in his sleep. Then he started talking and yelling, and then he started acting out his dreams about 10 years ago. So people will likely recognize this as REM sleep behavior disorder. So this occurs during REM sleep, which is our vivid dream sleep. And as we discussed, we're usually paralyzed, but in this disorder, also called RBD, this process is lost. In the general population, 0.5 to 2% of people over 60 may have RBD. It's associated with Parkinson's disease, but also with other disorders from alpha-synuclein, the pathologic protein in Parkinson's. So only maybe a third of people with Parkinson's have RBD, but by most estimates, over half of people with dementia with Lewy bodies do, and nearly everybody with multiple system atrophy. Those are 2 other disorders that are also linked to alpha-synuclein. So while those disorders are less common, they're more likely to have REM sleep behavior disorder. That said, if someone experiences REM sleep behavior disorder, they're more likely to go on and develop Parkinson's and these other disorders, just because Parkinson's is much more common. So this is what the loss of REM atonia may look like on a sleep study. So there's a lot of squiggles here just to orient you. At the top, we have the EEG. The green are the eye movements, and they're going up and down quite a lot. So this is REM sleep. And then underneath that, we have leads that are EMG, they're marking muscle tone. So this blue one is chin, the red is the right arm, and the purple is the left arm. Those should be very flat, and yet they're, as you can see, very thick, and the muscles are activated. And this individual looks asleep by the EEG at the top, but he was actually holding up his arms and conducting. So this is REM sleep behavior disorder. So how do we treat it? So one big thing is focusing on safety, making sure there's no sharp objects by the bedside, that people either have something soft on the floor next to them or actually put their mattress on the floor so they don't lunge out of bed and break a rib, as this patient did. And then melatonin is commonly used as a first-line treatment, and clonazepam is also used at times. Other medications, such as some medications used to treat Parkinson's or used to treat memory impairment, are also effective at times, but those are kind of less clearly effective, and melatonin and clonazepam are really considered the first-line treatments, alongside making sure the sleep environment is as safe as possible and the bed partners are as safe as possible. And sometimes people do decide to sleep in a separate bed to keep a bed partner safe. Okay, the final case is Mr. B. So he was a 75-year-old man with Parkinson's disease, and he came into clinic complaining of frequent awakenings, and he woke up in the morning and he still felt very unrefreshed and was very sleepy during the day. And he lives alone, but he recently shared a room with a friend while traveling, and his friend said that he was gasping and having breathing pauses overnight, prompting him to seek help for this. So what does this gentleman have? He has obstructive sleep apnea. So you can see on the right here, this blue line indicates air coming in the nose, going down the airway in normal breathing. But people who are snoring and partially obstructing their airway, you can see the soft palate and the tongue collapse back, so there's very little space and less air is getting in. And then when there's complete obstruction, no air is getting in. So people are periodically obstructing their airway. And then from here, the body says, oh no, and wakes up and opens up the airway. And then as they fall back asleep, this often happens again. So it can happen over and over and over and over again throughout the night. So obstructive sleep apnea is characterized by recurrent collapse of the airway. And while it's not clearly more common in Parkinson's disease compared to the general population, it's just very common in the general population. Estimates suggest maybe about a quarter of older adults have sleep apnea. It's diagnosed by a sleep study, and it may be less linked to weight in Parkinson's disease than other populations, but we do know that age and weight are major risk factors for sleep apnea. As you get older, your tissue gets more relaxed, it collapses more easily. As you gain weight not just in the midsection as people think about, but in the neck, in the tongue, and so the airway can collapse more easily. And then it's typically worse laying on the back. So one concern in Parkinson's is that it's harder to move to other positions, and that could be an additional problem, because we tend to see the airway collapses more easily and the tongue collapses back, related to position. How do we treat sleep apnea? So the mainstay of treatment is something called CPAP, or continuous positive airway pressure. There's a few pictures of that here, wearing kind of different masks and machines related to this treatment. Basically, it pushes air in to kind of dent the airway open or keep the airway open with extra pressure. Sometimes it's treated with an oral appliance. It's made by a dentist. There are circumstances where surgery is used to remove soft tissue or even kind of change the bony structure of the face. Weight loss for people who are overweight is a big part of treatment. And then there's some kind of a newer device that may help for more mild sleep apnea that is kind of similar to a CPAP mask, but doesn't have a machine, where it just makes it harder to breathe out and creates a little expiratory pressure. So all of those are possible treatments for sleep apnea. So to finish up here, if you're having trouble sleeping, what will your doctor want to know? So I think it's incredibly useful just to understand when someone's having trouble sleeping. When do they get in bed? When do they get out of bed in the morning? What's the sleep latency? How long is it taking to fall asleep? What's happening overnight? How often does someone awaken? How long is it taking them to return to sleep? Are there snoring or other abnormal sounds at night? Are they sleepy during the day? Fatigue, trouble concentrating? What's movement like in the night? Is there rigidity, dystonia, restless leg symptoms that might be interrupting sleep? And then what kind of behaviors are occurring at night? Is there dream enactment that needs to be further discussed. So in summary, sleep is incredibly important for so many aspects of health in life. This includes memory consolidation, emotional processing, decreasing sleepiness. And sleep problems are very common in Parkinson's, a huge range of sleep problems, including restless leg, insomnia, hypersomnia, REM sleep behavior disorder, and obstructive sleep apnea. And many of the treatment approaches that we use in Parkinson's are the same ones that we use in the general population. And really important things for maintaining healthy sleep includes daily exercise, really good sunlight during the day, and minimizing minimizing light in the evening, and then a very stable wake up time is an important part of healthy sleep habits. All right, so I think that is all I have. I'm happy to take questions. Thank you so much for listening throughout this period of time. So this is just a bit about our clinic. We have a neuropsych sleep clinic that is embedded within the neurology clinic at UCSF. So we see people who have any kind of sleep problem, but we really have a focus on people with neurologic and psychiatric issues. And so we do see a number of patients who have Parkinson's disease and sleep complaints. All right, I'll go ahead and stop my share, and I'm happy to answer any questions if there are any.
That's terrific. Thank you, Dr. Ashbrook. Super informational. A lot of good stuff there. We may have you go back to that in a minute if it's pertinent, but Monique and I can start scrolling down through a long list of questions that have been rolling in. Some of them I maybe should have jumped in with you in the middle of your deck to stay contextual, but we'll try it anyway here. Several questions here in the cannabis category that I'll try to fold multiple into one. They're curious about how CBD might work for sleep versus THC and the sub flavors of sativa versus indica.
Yeah, I can quickly answer that by the answer of I don't know. So I don't have that information. It really isn't out there. I mean, you can go to a cannabis dispensary and you'll get somebody behind the counter telling you those answers, but those aren't like research based. They may be experience based, but there really hasn't been adequate funding of how cannabis affects sleep, which is frustrating because it's been around for medicinal use in California for a very long time. And of course now recreational use as well. And it's really widely used. And I have people coming in all the time using it from, many different walks of life, or having tried it. And we really just don't have adequate information. We know that people feel like it maybe helps them sleep. We also know that people feel like alcohol helps them sleep. And we know that alcohol is really bad for sleep. So just because it feels like it helps doesn't mean it's beneficial. It may be like there's a little bit of research suggesting that chronic use decreases very deep sleep. So it may be that over the long term, it actually is detrimental. And we do know also on stopping, people can get some kind of rebound insomnia. But a lot of information we don't have, and I very much do not have kind of the details about exactly what you would want to use if you were to seek out cannabis to help with your sleep.
Yeah, that would be helpful.
If someone wants to fund that kind of research, I think it would be very, very welcome to the sleep community.
But it's hard to do that kind of research because it's federally controlled substance. So
it's hard. Yes. And that's a big part of why it hasn't been done. But I think through at least national funding.
And yet companies are still out there marketing CBD, at least products that proclaim sleep benefits. So
right. So I imagine we'll get more information over time, but we haven't yet, which I think we're still hoping for.
Okay.
So I have a question about magnesium. I noticed that you didn't mention that today in your talk as something that was good for sleep. And I know that I take it every night and it seems to help me sleep and with some sort of muscle cramps in my legs, which isn't restless leg syndrome. So I don't know if it's ever treated for restless leg or what do you think about magnesium?
I think magnesium is fine to take. I think it's safe. When it's been studied for insomnia, it hasn't panned out. Like the research studies have not shown it's beneficial. Hence I didn't mention it, but a lot of people feel like it is beneficial. So maybe the research studies just haven't captured the right population. I think it's reasonable to take, and sometimes I recommend it if people are really kind of searching for alternatives, but without kind of strong evidence to back it up. We try to lean on things that we think are more likely to work, but I think it's fine to take. And I think it is likely that there are some people who it does in fact benefit, because I've definitely had a number of patients and who really feel like it's made a distinct difference. And then for muscle cramping, which I didn't talk specifically about today, it may be useful as well, along with stretching and hydration and avoiding alcohol.
And are there variations of magnesium one should avoid, or sub ingredients that are not good for us in magnesium that are?
Not that I know of, no.
There are different forms of it. I know my
There are
naturopath
different
suggests,
formulations.
magnesium citrate, particularly because it doesn't loosen up the bowels like maybe the other forms of magnesium. That's can be an
Yeah,
unwanted side effect.
Yeah, the main side effect is people get like loose stools or diarrhea, in which case, if you were to try it and you experience that, reducing the dose or stopping or trying a different formulation is the next step.
Cool. Howard has an interesting question here. Any research on variation of sleep problems over seasons of the year, such as between winter and summer solstices or solstice versus equinox?
So we think about circadian rhythm when we think about the different seasons and light exposure. And so certainly people can have different sleep issues based on kind of the outdoor lighting. So we may see people who are really reliant on good morning light to get up, that can be harder in the winter, especially if they're trying to get up before the sun has risen, or the inverse, people who are incredibly sensitive to evening light and might be trying to go to bed early. So I think that's kind of the main context that we think about it in. And, people who are extreme early birds or night owls, it may be particularly important, or people who are working in shift work positions, where maybe outdoor lighting better or worse aligns. And so I think it kind of depends on the individual, how it might affect them, but it's something the sleep community thinks quite a lot about.
And for people who would like to use a light box, do you recommend it all year long, or is it something that's just better in the winter?
If you're targeting a sleep issue, I would recommend it all the year long.
Mm-hmm.
If you're targeting, I think they've kind of been popularized. Many people have heard of them in the context of seasonal affective disorder, in which case you would use it just in the winter if that's what you're targeting. But, I talked about in this presentation for daytime sleepiness, in which case you would use it all year long. And, we use them also for circadian rhythm disruption, in which case you would also use it all year long.
There's a lot of hype around blue light as well right now. I know my son was like, I need to get some blue light glasses. I mean, he's on a screen all the time. So is there any research to show that exposure to blue light is somehow changing sleep?
Yeah, the reason that blue light is such a focus is because these cells in the back of the eyes, called the retinal ganglion cells, or the intrinsic photosensitive retinal ganglion cells, RGCs, that talk directly with your suprachiasmatic nucleus, your central timekeeper. They are specifically responding to blue light. So that is kind of the area of the spectrum that these eyes respond to, that these cells respond to. And so that's the reason that there's such a focus on blue light from a sleep perspective. And so broad spectrum light includes blue light, so it gets the job done. Sometimes we do say getting blue blocking glasses for the evening may be a way to minimize like circadian disruption, have your body not think that it's still daytime, specifically with like not the blue blocking glasses that look just like regular glasses that block only a tiny amount, but like really robust ones that are like orange or red tinted may be effective at kind of reducing all of that exposure, where we think your brain is getting confused about when it's daytime, when it's nighttime because of all the light exposure. If it's just getting red light, it may be better. But it's complicated because these cells also speak to each other. So even if you're just blocking blue, if you're still getting some light, some people think that can still be problematic.
Okay. And to sort of extend on the circadian rhythm conversation, Kathy asks, I'm trying to remember your graph there of the sleep process and the The other, should people wake up with the sun and go to bed shortly after sunset? Is that healthy, or does that jive with the circadian rhythm, in other words?
So the way we think about it is that people fall at different what are called chronotypes, or the kind of the manifestation of when is optimal for you to sleep. And some people are early bird people and some people are night owls. And if you try to go to bed when the sun set and when the sun rose, you might in the winter be trying to sleep for, over 12 hours, which is unrealistic. And some people naturally want to go to bed early and awaken early. And so there's not one right time to sleep. But there may be a right time for your body. And if you're trying to fight that, that can cause a lot of problems as well. So when people have kind of a natural tendency earlier or later, sometimes leaning into that can lead to higher quality sleep. And then we do think a lot about light exposure. So people who are natural night owls, sometimes getting really good sunlight exposure in the morning can actually really help them get on a more conventional schedule if that's their goal. And then the inverse, people who are naturally early birds, evening light can actually help them get on a more conventional schedule.
And I suppose sticking to a rhythm one way or another, regardless of sun up, sundown, is important.
Yeah, so you get more refreshing sleep if you're more regular with your sleep timing, and thinking about what is your best rhythm.
Yes.
I thought that was one of the more interesting things that I learned about sleep, is the consistency of bedtime and wake time and how important that is. I mean, it seems to be very consistent across all, recommendations for sleep hygiene.
Yeah, I'm not, that's for treating insomnia. We think it's important for just kind of letting your body know what to expect. But there's also some more and more research that for kind of other biologic functions, that predictability is also actually quite important.
Mm-hmm. And what about the sort of differences between, I mean, I know you touched on this a little bit with regard to specific conditions, but like in general, women and men, and maybe what the role of sort of hormones might play for women in their sleep. Two things sort of stepped out at me. And one of the first case study you did, you said the woman started having sleep problems after she was pregnant for the first time. And of course that, lightning bells for me, because I remember after I had kids, I never slept well again. And I thought that was part of just being a mom, and you're always sort of, worrying and things like that. But there's a question in the chat too about someone who was on hormone replacement therapy, and that really helped some of their sleep, but yet they still notice maybe a 1 week during the month, they maybe don't sleep as well still. So
yeah, I mean, we definitely know that hormones have some influence on sleep, and it's still being teased apart. So things we know, progesterone makes people sleepy, and people who've been pregnant probably know, right, in the first trimester, maybe even into the second trimester, you're very, very sleepy. And that's contributed to the rise in progesterone. And that may also influence people's degree of sleepiness just during their menstrual cycle. And some of the other roles of hormones are kind of less well understood. We know people experience sleep changes around menopause. Actually, so the other thing about progesterone is it makes people sleepy, but it's actually respiratory, kind of helps protect people's airway. So after these hormones drop with menopause, we see rates between men and women of obstructive sleep apnea become similar, whereas premenopausal women are much less likely to get sleep apnea, probably because their airway does not collapse as easily. We see a lot of people experiencing insomnia around menopause, though that's been difficult to tease out. But some people do find that hormone replacement therapy is helpful. And whether that's related to like kind of temperature fluctuations or hot flashes at night or something above and beyond that, I think people are still trying to work out. And I think it's probably been an understudied area, along with a number of other issues that are specific to women.
Dr. Ashbrook, someone with coincidentally the same name as my wife, asks, what about aromatherapy and using something like lavender at night while trying to fall asleep or helping to fall back asleep?
I don't know much about aromatherapy. I mean, there's a number of different supplements that people take orally. I mean, I'm assuming this is obviously just smelled, that have been studied, and there's many different, magnesium among them, that have only very small amount of research behind them. You know, people come in trying many different over-the-counter supplements for their sleep. And none of them have kind of robust research behind them, kind of get to the level of being routinely recommended by me or many of my colleagues in sleep medicine. Maybe because some of them don't work, and maybe because some of them just have not been adequately studied to really understand, like, do they work well enough to widely recommend above and beyond some of the other things we have much better research for. So lavender is one of the kind of different things that's been studied. I don't know enough about. My guess is that aromatherapy with lavender has not had very robust research, so I don't have a specific comment on that.
And probably no counter information either, that some aromatherapy might be bad for our sleep.
I don't think it's probably bad for our sleep. Yeah, that's unlikely. So there are, yeah, I think it's probably reasonable to try if someone wants to invest in it. You know, sometimes I see people investing quite a bit of money in interventions that don't seem to be effective, and so that's a concern, but otherwise it's probably reasonable.
Okay.
I noticed in one of the slides you had said that, you know, stay in your bed when you're asleep, and then when you're awake, get out of bed. So the idea is, you know, if you wake up in the middle of the night and you can't go back to sleep, it sounds like you're saying you should get up out of bed. But I'm wondering, like, for a lot of people, there's a comment in the chat, and also my own experience is that it's hard to get out of bed. It's warm and it's cozy, and
Yeah.
it's really hard. So what do you do? Should you really force yourself to get out of bed if you're
Yeah,
lying
I
awake?
think that's one of the tough ones. So that is a standard part of cognitive behavioral therapy for insomnia. So I would say, like, when I see people in clinic, I don't, the cognitive behavioral therapy for insomnia, or CBTI, is done by our sleep psychologists. It's actually not by me and my physician colleagues in our clinic. We refer people to our psychologist colleagues who focus on sleep and insomnia. So when I make recommendations, I generally don't push that one, because I agree that, like, it's really tough, and doing it in isolation, I often see people feeling like just frustrated. I think if you're going through the CBTI program, it's been incredibly well researched with many different studies, supporting that it's quite effective. And so if going through that, I think it is an important recommendation to adhere to along with the other ones, because we know that it's really the other that seems to be so, that piece very much includes. But in isolation, it may be effective. And so I wouldn't probably focus on that piece. But some people do find it kind of relieving to hear that it's okay to get up. Like, they don't have to always be trying to sleep from whatever hours they've designated, that if they're not going to sleep, they don't have to be in bed. And the idea behind the recommendation is kind of twofold. One, to increase your sleep drive. If you're laying there for 2 hours, kind of mostly awake, but going in and out of light sleep, you're bumping down your sleep drive without getting quality sleep. But if you're not in bed, then your sleep drive is going to be higher when you actually get in bed to give yourself the chance to sleep. It also helps break the association. A lot of times we see that people have kind of like a Pavlovian conditioned response to being in bed, where they wake up and they, every single night or almost every night or at least once a week for a long period of time, they've been awake and frustrated. And so you begin to expect it. And then when you expect it, of course, it's more likely to happen. And so you have to break that cycle. But doing it alongside a sleep psychologist is sometimes important to kind of really get the most out of that one, because I think it is tough.
Right. I would worry that if I got up in the middle of the night, you know, when I wasn't sleeping, that the next night my body would be like, okay, it's time to get up at 3. And then I might sort of start into a pattern of, like, actually waking up for the day, you know, at 2 in the morning or something. But
yeah, it depends, right? So if you aren't normally waking up at then I wouldn't worry so much about it. But it's often in people who are every single night waking up then already. It also depends what you do. So we certainly discourage people from doing really rewarding things, like don't eat, because that does reinforce saying, like, look, I'm going to reward you with some food if you get up. You know, don't watch your favorite show. Like, don't do things that are very rewarding, because you don't want to reinforce the behavior.
Oh, that's a good tip, right? So don't start watching Netflix at 3 in the morning.
Right. right, from a light stimulation perspective as well, and a like, cognitive stimulation perspective. But exactly, so you want to do like boring activities.
Right? Knitting or something.
Yeah, exactly, with like a dim
Well,
light
not to
source.
disparage knitting. I mean, it's just
Right. Well, yeah, I mean, and that
Careful.
activity varies person to person. It depends who you are, what activity is the right fit for you.
So we've talked about these screens and bright lights being bad for us. Can you help new parents out here understand and better arm them with what to tell their children about not watching their screens before bed for us?
Yeah. I think,
Why, for example, why is that bad?
I think there's a lot out in the popular press and whatnot about kind of the detrimental effects of screens, of course. I think actually a big part of that is displacing sleep. So it's not even the circadian factor, it's the displacement, right? If you're like doing something that's very rewarding, you want to keep doing it. And yet you have a hard stop, got to get to school at 8 in the morning. And if you stay up late, you're just getting less sleep. So I think it's largely a matter of prioritizing sleep and doing things that displace sleep. If you're playing video games or doing something very activating, that can also make it harder to sleep. And then the light component, I think, has been a focus, but the research is a little murkier. But certainly, especially for teenagers, their internal rhythm is already very shifted. Like the whole population shifts to be more delayed in adolescence. And the mechanisms of that we don't perfectly understand, but evening light could be a component. And so that specific group may be even more sensitive to evening light. And so extra light in the evening might make it even harder to go to sleep just by telling the brain, like, it's still daytime. So certainly minimizing evening light. It depends on the individual and the individual circumstance, but by and large, like dimming the lights in the evening is a good idea if someone's having trouble falling asleep.
So not telling Junior that his eyes will burn out of his head is a
I don't know. It depends, I suppose. Maybe they will.
Alan has an interesting question that I don't quite understand. You probably will. Is biphasic sleep considered a normal pattern? What is biphasic sleep?
Yeah, so there have been a few articles, not by sleep professionals, but by like historians and anthropologists about biphasic sleep. And so people are, there have been some like New York Times articles, and they're basically, it's people who are sleeping in 2 chunks of time. So if you sleep for several hours, you're awake for several hours, and you go back to sleep. And there's reports that there may have been periods of time where that was a common pattern of sleep, whereas it isn't now. And I would say that we think that people get the most refreshing sleep if they're sleeping in a consolidated chunk. If someone is sleeping in 2 chunks and they are happy with their sleep, that's fine. But if they're not happy with their sleep, I would probably help them kind of consolidate their sleep by making some changes to sleep habits and sleep timing. And I think that this discussion of biphasic sleep, whether that was kind of necessitated by other factors, it doesn't seem like it's necessarily, there's not good evidence that it's kind of the natural way people sleep, though it was apparently the way some people slept in the past.
Okay.
We have a question here about the research connecting REM behavior disorder with Parkinson's and Lewy body disease. Can you go into that a little bit more? I mean, what is the association between those?
Yeah. So there's been a couple studies, for a while, people called it idiopathic REM sleep behavior disorder, meaning like idiopathic means we don't know what caused it. Like people would just develop this. But then it became more clear that a number of people were going on to develop Parkinson's or similar disorders. And so now there have been some studies that followed people over time. So took a group of people who had REM sleep behavior disorder and then followed them for 20 years or 30 years and saw that almost everybody goes on to develop Parkinson's. So there's a very clear association. It's like quite a strong association that, like, if sometimes there's other explanations, maybe medications or things like post-traumatic stress disorder, or maybe sleep apnea, maybe someone has another explanation, but by and large, almost everybody who develops REM sleep behavior disorder, sometimes over decades, but does ultimately go on to develop something like Parkinson's or one of these other disorders.
So it's one of the sort of precursor,
it's like a precursor
prodromal
yeah.
symptoms that
yeah,
we have,
exactly,
like losing
exactly.
smell. kind of is one of those also.
Exactly. Yeah. So that's a better way to frame it, I think, because sometimes people hear what I just said and think, well, maybe if you intervene on the REM sleep behavior disorder, you can change the course. And it's not like that. It's more like a marker. Like some people with Parkinson's, the kind of pathology moves throughout the brain from kind of the back to the front. And only once it hits the motor centers do people really know what's going on. But it may vary many, many years before affect other centers in the back of the brain that lead to this paralysis during REM sleep and interrupt it. So yeah, similar to the lack of smell, which can come like many years in advance. That is not very specific, right? Lack of smell can happen for many reasons, but the REM sleep behavior disorder is, rather specific. If it's happening, we definitely become more concerned that someone may develop Parkinson's or something similar.
Interesting. And is that a pretty long known correlation among the neurological?
I think it's been emerging over the last several decades. So I think some of the best studies were maybe 10 years ago, but like 15, 20 years ago, people were having an idea. So it's relatively new.
Interesting.
And what about sort of REM disorder is when you're sort of acting out your sleep, your dreams, right? And what about people who just have very active, vivid dreams? Like I have two people in my life who experience this, where they have very, very active, vivid dreams, and they wake up sort of feeling exhausted from their dreams almost. So there's no physical component to it, but somehow it's just not feeling rested because the dreams are so vivid.
Yeah, so we generally don't think that like vivid dreams should make someone feel unrested. So I would think about maybe some other pathology in that, and somebody like that. Do they have sleep apnea? So that's making them wake up more frequently, and that's leading to both kind of remembering vivid dreams and feeling unrefreshed. Is there some background anxiety that's leading to some kind of anxiety type dreams and feeling unrefreshed? Is there some other mechanism that's kind of leading to both? Is what I might think about for someone in that circumstance. But I would say, from a kind of sleep medicine, seeing patients in clinic perspective, we think about kind of what are the problems. If someone just remembers their dreams well or doesn't, those are both considered normal. So it's not something that's really like pathology and has been kind of studied from a perspective of needing treatment.
Interesting. Okay, time check here. We are at 10 minutes after 12, and we know that you are visiting family, Dr. Ashbrook, and we'd like to get you back to that. So maybe a couple more questions, Monique, and we'll wrap.
Sounds great.
I see, actually, I'll try to throw you two in a row here, Dr. Ashbrook. Robert asks if listening to music when going to bed can have any detrimental or positive effect, and we might throw in there any other audio treatments like white noise or nature sounds. And then Sally has a question around hypersensitivity. I think it means if one is diagnosed with hypersensitivity, is there any treatment for sleep disorder according to that?
So first, for the first part, I think some people find that listening to things as they fall asleep is relaxing, and I think that's fine. We try to avoid like very elaborate routines that can't be reproduced. So people don't kind of develop some sort of exquisite thing that they can only do at home as a falling asleep routine. But if listening to white noise or nature sounds or an audiobook or podcast helps someone fall asleep, I think that's fine. A lot of disruption while you're sleeping could potentially disrupt sleep. So something that's time to go off is probably better. But I think I don't think it's necessarily problematic if somebody finds that useful to fall asleep with. The second question about
Hypersensitivity.
Hypersensitivity. To be honest, I'm not sure I understand well enough. Hypersensitivity is not a specific diagnosis I'm familiar with beyond maybe hypersensitivity to something specific. So I don't have any recommendations for that.
Okay. Fair enough. Monique?
Well, this question is really interesting to me. Is that if someone's having a nightmare, should we awaken them, or is this sort of brain activity cleansing? I think the term might be pruning, right? Your brain is pruning, or no?
Yeah, Yeah, that's interesting. Like, I don't think we have any, as far as I know, good evidence that like you should let them experience it. We think about not waking people up in the context of sleepwalking type events, right? Like, which are different because those arise out of non-REM sleep
Mhm,
rather than REM sleep.
mhm.
And sometimes people can awaken, like this is especially in small children, but it can happen in people who are older too. They can awaken with a strong emotional response called a night terror without necessarily very, very, very detailed dream content, and
Mhm.
often don't remember it in the morning and are actually hard to fully arouse. In those contexts, we don't recommend waking people up, just kind of like guiding them back to sleep. But if someone seems to be having a nightmare, I don't know that there's specific guidelines around awakening them. I think probably it may be useful in providing some comfort. But if someone can fall back to sleep if they're not awakening during it and they just kind of transition through it, for events like REM sleep behavior disorder, many times people may look distressed and then transition through the event. They don't, in fact, wake up. They don't remember it, and they aren't distressed by it in the morning. It may be a marker of a problem, but it's not actually a major sleep disruptor. And we worry about it from a safety perspective, but you don't have to awaken somebody during an event. It's fine to let them sleep through it. So it probably depends on the individual. I don't have kind of a uniform guideline there.
Great, thank you.
Let's see. A question here from one of our attendees. If one has difficulty getting to sleep and staying asleep, but when they get to sleep, they swing their arms around and kick around, etc., what is the best solution? Would you recommend gabapentin or clonazepam, or is there something that addresses both?
So if they're kind of kicking and swinging their arms, that sounds like possibly REM sleep behavior disorder. I think probably I would need more detail to really understand what's going on. Um, but if it is REM sleep behavior disorder, we usually start with melatonin as the first step in treatment, and then sometimes clonazepam is used. But clonazepam is sedating, can have downsides, so it depends on the individual whether it's kind of thought that the benefit outweighs the risk. Um, if somebody is just having a small amount of movement, it may be more risk to use clonazepam than benefit, as long as they're safe.
And does clonazepam still have dependency concerns?
Yes.
There was also a question about clonazepam for someone who has epilepsy. Is that a concern to be taking it if you have epilepsy? Do you know?
Clonazepam is sometimes used as a treatment for epilepsy. It's not necessarily first, second, or third line, but it suppresses seizures, and that class of medications is used in emergency situations where someone's having prolonged seizures. So it treats seizures. So it wouldn't be a concern in that way.
Great. One other really quick question is, what was the recommended treatment for sleep attacks? Somebody was asking again about that. Do you know off the top of your head?
Oh, I mean, I think it depends on the circumstance. So looking at medication lists and seeing if there's something that can be removed. They're specifically associated with dopamine agonists. So if somebody is on a dopamine agonist and that medication can be removed. And then thinking about things that trigger excessive sleepiness. Does someone have sleep apnea? And then sometimes stimulants are used, like, a medication that helps promote wake, like modafinil, depending on the circumstance. Sometimes changing someone's sleep schedule or sleep habits or planned naps can also be beneficial. So I would say it depends on the circumstance for the individual.
And just to remind everybody, we will be sending out the presentation and the recording afterwards. So some of the questions that if you wanted to revisit the presentation, they might be answered there for the questions that we didn't get to, because there's still more questions coming in.
Still quite a few. I agree. Thank you for making that additional note. Actually, I have two last questions real quick for you, Dr. Ashbrook. Alexis asks if you would consider yoga among the positive exercises that we listed in one of your slides that can help sleeplessness.
Yeah, I think yoga may certainly be beneficial. I imagine there are studies of yoga and sleep, though I don't know them specifically, but meditation that can be a component of yoga can often help with relaxation, and physical activity we know is quite good for sleep, both kind of falling asleep, but also getting higher quality, deeper sleep exercise can lead to. So yoga could certainly benefit sleep from those perspectives.
One would think, right? And let's end with David's question. I like it because he answers it. Was this a fabulous talk? Yes. Excellent.
Thank
So,
you, David.
with that, let's wrap. And like Monique says, lots of questions have come in. We've tried to answer many of them. A few of them are still outstanding, but hopefully we will get your presentation up on our website in the next couple of days, and this whole recorded session up on our YouTube channel. So folks that registered for the event will get an email to that effect. Hopefully can get any other questions answered that way. Otherwise, Dr. Ashbrook, thank you very, very much for your time today. We
Absolutely.
appreciate it.
Thanks for having me.
Very informational, very interesting content. So, Monique, any thoughts?
That was fabulous. Thank you so much. Appreciate it.
Have a great rest of your
Take
day.
care.
And everyone
You
else,
too.
thanks for joining. We hope you enjoyed it, and we'll be in touch. Have a great Saturday, everyone.
All right, you too.
Bye-bye.
Bye-bye.
Bye.